with the first question. Still waiting for someone to join. We have a very interesting questionnaire today. I hope you all will enjoy it. Ready with some interesting stories as well. I mean, related to medicine. So, we'll wait for some more players to join. Okay, there you go. The first question. False regarding RH incompatibility. Get ready. I'll not read every option. Pick up, and we'll discuss the right answer. Yes, two members answered and one was correct. That is, incidence of RH incompatibility in the RH negative mother who is also ABO incompatible is increased dramatically, which is a wrong answer. Now, RH incompatibility we usually see in RH negative mother with RH positive fetus. So now, what is the take-home message from this question? Risk and severity of sensitization response increases with each subsequent pregnancy involving fetus with RH positive blood. An increased 1 ml of RH positive blood was shown to sensitize volunteers with RH negative blood. 1 ml, less than 1 ml is sufficient. Now, 30% of persons with RH negative blood never develop RH incompatibility even when challenged with large volumes of RH positive blood. Now, you must be suspecting what if the patient is, or what if the fetus is having ABO incompatibility with the mother, right? So, yes, there are some minor amount of incompatible blood which enters from fetus to maternal circulation, but before it reaches the maternal circulation itself, they are neutralized. So, we it doesn't affect the first child, but affects the subsequent pregnancies. That's all. That's the take home message. Let's go for the next question. JD has the right answer. Question number 2. It's about coagulation. Which of the following clotting factor is a transglutaminase? Factor 5, 8, 9, 13. It's a transglutaminase. Time is up. See, all clotting factors are serine proteases. Most of them are serine proteases. They cleave proteins and act. These cleave the proteases and act in the pre-synthetic form. Okay, and also they circulate as inactive zymosins within the blood. Now, factor 13 is an example of transglutaminase, which is the right answer. Factor 9, it is a serine protease. And factor 5 and factor 8 are glycoproteins. So, this is what you should know, that most of the clotting factors are serine proteases. Factor 13 is a transglutaminase. And yes, we have Harsha answered this question, right? 24, Ram, JD. Sihu, Min, Priyanka, Golgappa Man. Come on. Third question. False regarding immediate hypersensitivity. Immediate hypersensitivity. What could be false? Hypersensitivity is a very important question and a favorite question for everyone. Yes, patients who are atopic are thought to have higher Th1 to Th2 cell ratio, which is the wrong answer. Okay. Now, what are the types of hypersensitivity you know? 4 types are there. Type 1, type 2, type 3 and type 4. Type 1 is immediate IgE. Type 2 cytotoxic, which is IgG and IgM mediated. Type 3 is immune complex. And type 4 is delayed. Some say delayed is a type of type 1 hypersensitivity. But that, how is it related? Let us see. Now, as we all know, immediate hypersensitivity reactions, they are mediated by IgG. And we have JD who answered this question well. Yeah, next question. Question 4. It's about AML, acute myeloid leukemia. Pathologist's favorite and terrific question. AML. You have lots of variants in AML. So there you go. The answer is yes. Turner syndrome is a risk factor. Okay. Most of them wrote correct. So then in that case, what could be the syndromes associated with AML? Bloom syndrome, Down syndrome, congenital neutropenia, Fanconi's anemia, and neurofibromatosis. So these are the syndromes which are related with AML. And MDS, myelodysplastic syndromes, with less than with excess blasts less than 20, they don't fall into the category of AML. Only with blasts more than 20% they fall, and blasts more than 20% in the bone marrow they fall for the AML. You can label them as acute myeloid leukemia. Ravi Kumar, very good. Now question 5. False regarding non-small cell lung carcinoma, the lung. So, what is false? Time's up. Yes, RAS gene mutations are identified in adenocarcinoma that develop in persons who do not smoke is the wrong answer. So the rest all are right. Now, lung carcinoma, it is basically pathologically divided into two types, small cell lung carcinoma and non-small cell lung carcinoma. So non-small cell lung carcinoma, which are most common, and it is in fact divided into adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Now, let us get into the pathophysiology of the genetic susceptibility. In what they have studied recently is about the RAS oncogene. It is three types: KRAS, NRAS, HRAS. So these, other than these, maybe you must be thinking what other mutations are there. You can see the c-MYC gene, retinoblastoma, P53, and CRAS. So you have these mutated oncogenes which are responsible for small cell, non-small cell lung carcinomas. So these non-small cell lung carcinomas, these RAS mutations are seen in smokers and in adenocarcinomas. That's it. So it occurs in almost all sorts of adenocarcinomas. Yes, JD, good. 24, Ravi Kumar, Muhammad Sadiq, good. Sixth question. This is a favorite question. False regarding lipid granulomas. We can talk about it. So time is up. The answer is giant cells in 95%. It's false regarding lipid granulomas. Now, what is lipid granuloma? You know what is the other names for it? There are several names for it. It is intraperitoneal lipid granulomas, lipogranuloma, oil granuloma, baselinoma, and the history behind it is very interesting. Dated back in 1888, this German, I don't remember the name, but the German surgeon, what he did is whenever he cut open the peritoneum, he just opened he corrected the deformity, and as he opened and when he want to refix it and close the peritoneum, he's afraid of the post consequence, that is adhesions. So to avoid the adhesions, what he used to do, he used to add the sterile oil or olive oil, lubricate the intestines and the gut inside, and then he used to close the wound. So it was the common practice then, but after that 1908, slowly they started modifying it and started using sterile oils, mineral oils, Vaseline, and all. And then again, when you come back to 1934, there the census worked. They thought that no, there is something wrong going on here. Like these oil, they are engulfed by the macrophages and they have started granulomatous reactions. And later, any granulomatous reactions eventually develop calcifications as they are leading to the necrosis of the, the death, the cell death, as they are compressing it. So, and what they're reported as most frequent type of granulomas in the bone marrow? Yes. Usually associated with lymphoid aggregates and sinusoids? Yes. Loosely spaced macrophages contain fat pacules of varying size. Yes, JD, Oddity, Inamori Sairam. Come on, you should keep up. The next question. False regarding autoantibody tests used in the diagnosis of systemic lupus erythematosus. Yes, time's up. It's he and Ka is positive in minocycline-induced drug lupus. Yes, so that's false. Now, what is SLE? Systemic lupus erythematosus. Favorite question for most of the examiners. So, what is it? Let us talk about the diagnostic studio. What happens behind the screen and what actually are important ANCAs, anti-neutrophilic antibodies, anti-double-stranded DNA antibodies, anti-Smith antibodies, which are more specific, anti-Sjogren syndrome A and anti-Sjogren syndrome B, anti-ribonucleoprotein antibodies with anti-Smith, anti-SSA, and anti-SSB that is responsible for mixed connective tissues, anti-cardiolipin antibodies that is for screening, antiphospholipid antibody syndrome, lupus anticoagulant, direct Coombs test, antihistones, and in that you have P-ANCA minocycline. It is responsible for the lupus of that. So Mohammed Sadiq, JD, Oddity. Question 8, interleukins. So this question is related to interleukins. What is false related to interleukins in the given options? Interleukin 6 causes neutrophil chemotaxis. Interleukin 10 inhibits Th1 cytokine production. Yes. Interleukin 6 causes neutrophil chemotaxis. Then what causes neutrophil chemotaxis? It's interleukin 8. And now, how many interleukins are there? Nearly 50 are there, but those are not clinically important for us. Inamuri Sairam, yes, he's again on the lead. Sadiq. Now let me see who are doing good job down below. False regarding multiple myeloma. So the level of beta 2 microglobulin is not increased in patients with renal insufficiency without multiple. Yes, time is up. Yes, majority of them wrote correct. It is 5. Level of beta 2 microglobulin is not increased in patients with renal insufficiency. No, that is wrong. It is actually what is multiple myeloma? Multiple myeloma is a monoclonal plasma cell neoplasm within the bone marrow where there's proliferation of these plasma cells and there is M protein hike and the destruction of the bone. So what tests you usually do? Serum and urine assessment for monoclonal proteins, serum free light chains, and then you have Benzione's proteinuria. Just recollect what all you can. And beta 2 microglobin is a surrogate marker for body tumor turnover. Okay, and the burden. CRP, surrogate marker for interleukin 6 activity. Yes. Okay, next question. Sickle cell anemia. What is false regarding sickle cell anemia? Sickle cell RBCs have increased IgG on cell. Sickle cells stop to express very late antigen on the surface. Approx 1/3 of RBCs. I think you should tell this right. Uh-oh. It's what is false regarding sickle cell anemia? This question filtered the cream off. Sickle cells, they don't stop to express it. They do express this very late antigen. Okay. And what happens? The molecule VCAM, it is upregulated in hypoxia and inhibits the nitric oxide. So inhibition of nitric oxide, which is a vasodilator, what will happen eventually? Because of its inhibition, there is vasoconstriction, and it constricts the vasculature, causing vaso-occlusive crisis. So the answer is B. And sickle cells have increased IgG on the cell surface, yes, and the sodium and potassium are responsible for the sickling. JD, Inamosaram. It's dystrophic calcification. Basophilic calcium salts deposits aggregate first in which? Lysosome, mitochondria, smooth endoplasmic reticulum, rough endoplasmic reticulum. This is a blind answer. You should get it right. Dystrophic calcification. Yes, I'm happy. Majority wrote mitochondria. The answer is mitochondria. So I hope you remember dystrophic calcification and metastatic calcifications. This, okay, let's go to the next question. Decreased bilirubin UGT activity has been attributed to an expansion of thymine adenine TA repeats in the promoter region of the UGT1 TA gene in Crigler-Najjar syndrome 1, Crigler-Najjar syndrome 2, Gilbert, and Rotor syndrome. Oh, 2 wrote Gilbert syndrome, which is the right answer. And why Crigler-Najjar 2? Okay, Sairam is on the lead again. Question 13. False regarding MHC. I'll give you a clue at the end. Something to remember about MHC. What is false? Yes, 4. Yeah. So it's, you remember when I say MHC class 2 and CD4 and CD8, please remember rule of 8. So MHC class 1, it is T helper CD8. And MHC class 2, CD4, cluster differentiation 4 with T helper cells. So this you remember. CD4, MHC class 2, CD1, CD8, MHC class 1. Question 14. False regarding rheumatic fever. Remember, major bacteria, minor bacteria develops following pharyngitis with group A, beta, hemolytic streptococcus. Yep, time's up. Yes, again here we have the correct answer for this question is B. So rest all are correct. What is the take home message? Only infections of the pharynx can initiate or reactivate rheumatic fever. It is not skin. Okay. So the rest, all 3 options, they match very well for the rheumatic fever. Ravi Kumar, come on. Question 15. This is about thalassemia. Thalassemia. Hemoglobinopathies, I hope you remember. So which is false in the given options? Yes, thalassemia exhibit decreased iron stones in marrow? No. So there is erythroid hypoplasia, whereas increased iron stores are seen. Okay, so all severe forms of thalassemia exhibit hyperactive marrow with erythroid hypoplasia. And yes. Question 16, it's about ulcerative colitis. Think about it. Inflammatory bowel diseases. Yep, time is up. Good. I'm happy. Most of you wrote correctly. That is, crib distortion can be seen also in acute infectious colitis or Crohn's disease, which is a wrong answer. So now ulcerative colitis and Crohn's disease. Please remember, these both are inflammatory bowel diseases. Now ulcerative colitis is superficial. It involves only mucosa and submucosa. Crohn's, it involves deep. Now who is there in Remus? Okay, good. Now, false regarding diabetic nephropathy. Yes, please read the options. Okay, the answer is insulin dependent diabetes mellitus leads to end stage renal disease more commonly than non insulin dependent diabetes mellitus. I don't agree with it. That's the wrong answer. So that is a false. Diabetic nephropathy, it's very important. It's persistent albuminuria with more than 300 mg per dl or 200 microgram per minute. That is, it's a label. You can label the patient with a history of diabetes as diabetic nephropathy. And insulin dependent diabetes mellitus, it is less likely than non insulin dependent diabetes mellitus. Okay. Now, key change in diabetic glomerulopathies. What happens? Glomerulonephropathies. The thing is glomerulosclerosis, where the size of the kidney remains the same. Okay. So we cannot, even the patient ends up with renal failure, but still you don't differentiate it as chronic renal failure as it is due to sclerosis. Okay, next question. Hemolytic anemias. What is false about hemolytic anemia? Okay, yep, time is up. Okay, so four wrote correctly, which is B. So now hemolytic anemia, what is haptoglobin? Haptoglobin is basically a acute phase reactant. So serum haptoglobin is a criteria for moderate to severe hemolysis? Yes. So decrease in haptoglobin is more likely in extravascular hemolysis than intravascular hemolysis? I don't think so. Intravascular hemolysis will give more amounts of haptoglobin. Extravascular hemolysis, it is characterized by the presence of spherocytes due to increased MCH and MCHC. And now serum LDH is criteria for hemolysis. Extravascular and intravascular hemolysis, you have to remember it. It's important. Mohammed Sadiq, Sairam, Bob. I see a new name. Ram Ram. 19th question. Infective endocarditis. False regarding infective endocarditis. Duke's criteria is something I remember in my MBBS time. Yep. What is the right option here? Yes, I'm happy. Majority wrote uh, Staphylococcus aureus infection is second most common cause of nosocomial bloodstream infection. It is the wrong answer. So I hope you all know about infective endocarditis very well. So let me not stretch more about it. Let's skip to the next question. Sadiq, Sairam, Bob, JD, all come in. Last question. In a person with situs inversus, recurrent sinopulmonary infection, and sterility, the mechanism most likely responsible for these findings is defect in humoral immunity, immune complex disease, defect in ciliary structure and function. Oh, yes, very good. I'm very happy with this answer. Majority wrote correct. It is a defect in the ciliary structures and function. That is the reason why. And can you recollect what syndrome it is? Cartagener's syndrome. So, very good. The Dineen arm is affected in this syndrome. Oh, where? There it is. Idamur Sairam, 630 points. You were the hero of this quiz. But I'm happy that many of you participated in this. So I'm glad to conduct a quiz for you this time. Let me see you some other time. And till then, I'll come up with another set of 20 questions. Take care. Have a good day. Bye bye.